Hello and welcome. My name is Julia Priestley and I'm one of the joint CEOs of the BTF. We're very pleased that so many of you have joined us for tonight's meeting, which is the first of our Meet the Expert webinars for this year. This is the second patient event we've held about thyroid eye disease. The first was in the autumn of 2020. And we're finding that we're getting more and more inquiries from people who are looking for information about thyroid eye disease, and some of whom sadly are struggling to get the specialist care. And since early diagnosis is so essential for effective treatment of thyroid eye disease, we know that the delays that some people are experiencing, caused often, of course, by the pandemic, are causing lots of distress. Improving care for patients with thyroid eye disease has been a key objective of the British Thyroid Foundation since it was founded 30 years ago. And we hope that the information we share with you on our website and our patient leaflets and at events like this can make a real difference. So just before I introduce our speakers to you, I just wanted to give a quick plug for the work we do. Almost all of our funding comes from membership fees and donations. So if you'd like to support our charity, enable us to continue providing free information events like these, please do consider joining the BTF as a member or making a donation, however small. And now to our speakers, who have kindly given up their time tonight. Dr. Nicola Zammitt is a consultant endocrinologist and is a clinical director of the Edinburgh Centre for Endocrinology and Diabetes. And Dr. Justin McKee is a consultant ophthalmologist at NHS Lothian. They both have a particular interest in thyroid eye disease, and they work together in the Thyroid Eye Disease Joint Clinic, which runs weekly in Edinburgh. I'm sure many of you will have questions, so while they're speaking during their presentations, please type your questions into the Q&A box that you'll find at the bottom of your screen, or either during the presentations or after. You'll appreciate that the speakers will only be able to answer very general questions. So as ever, if you have a specific concerns about your own health, then please do contact your own doctor. We might not be able to get through all the questions in the time we have tonight, but if yours is missed, then you're very welcome to contact us after the meeting and we'll do our best to answer it that way. And our speakers have kindly said they'll answer your questions after the event. And finally, the webinar is being recorded. So if you miss anything or you'd like to share it with anybody else, then you'll be able to find it, a recording of it, on our website and on the BTF YouTube channel in a few days' time. So without any more from me, I'm delighted to hand you over to Nicola and Justin, who will be talking to you tonight about the diagnosis and management of thyroid eye disease, what you need to know. Thank you.
So Julia, thank you very much for the kind invitation to speak this evening. As you said, Justin and I run the Thyroid Eye Clinic at Edinburgh. In fact, we've been doing the clinic together this afternoon. Oops. There you go. And Justin's a medical ophthalmologist, which means he's an eye doctor, but he doesn't do operations. And I'm an endocrinologist, so I specialize in the thyroid side of things. And because many members of the audience might have tuned into the previous BTF webinar in November of 2020, I just wanted to highlight that this illustrates really the multidisciplinary nature of looking after people with thyroid eye disease. So the people who did the last webinar, Rashna Murthy and Jonathan Roos, are oculoplastic surgeons, and we have many other members of our multidisciplinary team, including squint surgeons and ENT surgeons. So it really is a group effort to look after people with Graves' disease. So what I'm going to do is give a brief recap of Graves' disease, what it is, and how eye disease develops, and talk a little bit about what my role is in the Joint Thyroid Eye Clinic, and then Justin will go on to talk about his role in the eye clinic. Both of us will make reference to a number of guidelines which underpin how we run our clinic, and hopefully at the end of it you'll get a flavour that the person with thyroid eye disease is very much at the heart of everything that we do. So Graves' disease is the commonest cause of an overactive thyroid, and it's what we call an autoimmune disease. In other words, the immune system makes antibodies which attack the thyroid and make it go overactive. And because the antibodies attack the entire thyroid gland, the whole gland becomes swollen. And in the picture on the left, you can probably actually see that this lady's thyroid is enlarged in that typical butterfly or bow tie shape. And when you do an uptake scan of the thyroid shown there on the right, you can see that the entire gland lights up and the whole gland is overactive. And that's because of that direct antibody attack. But those antibodies can also attack the eyes, and we'll come on to that in a little bit. So we measure the antibodies, the TSH receptor antibodies, or TRAbs for short, and that helps us to make a diagnosis of Graves' disease. What are the symptoms of an overactive thyroid? These will be familiar to many people. And essentially, your metabolism goes into overdrive. Everything runs a little bit too fast. So even though you're really hungry and you eat a lot, the weight often drops off. People feel tired and worn out. They're trembly, sweaty, shaky. They're aware of their heart racing. They can develop diarrhea, and the periods can become light or absent. And people often feel quite irritable and edgy and anxious when they've got an overactive thyroid. We know that about 1 in 4 to 1 in 5 people with Graves' disease will develop symptoms of thyroid eye disease. It's important to say at this point that although having an overactive thyroid and thyroid eye disease is the commonest combination, it is actually possible to get thyroid eye disease with normal thyroid function tests or even with an underactive thyroid, but almost always we see the presence of these positive TRAb antibodies. So this diagram really covers what the TRAbs do. It's a little bit busy, but I'll walk you through it. In the middle of the diagram, in the red circle, we've got the B cells, which are cells in the immune system that make antibodies. And in this case, these are TSH receptor antibodies, or TRAbs. Down in the bottom left-hand corner, we've got a picture of the thyroid. And the thyroid is controlled by a hormone released from a gland in the brain, the pituitary gland, and that hormone is called thyroid stimulating hormone, or TSH. So in other words, these TSH receptor antibodies dock into the place in the thyroid where the thyroid stimulating hormone would normally dock to tell the thyroid to make T3 and T4. And so the high levels of antibodies cause high levels of T3 and T4. But then if we swing over to the right-hand side of the diagram, these antibodies also act on various tissues behind the eyes. And without getting too technical about the different tissues, essentially what it causes is accumulation of fluid and swelling, and that causes the inflammation and swelling in behind the eyes that cause the symptoms of thyroid eye disease. So here's a list of some of the symptoms of thyroid eye disease, and these are all listed in the BTF leaflet on thyroid eye disease. I'll show you a little screen grab of that later because we use that very frequently in our clinic. But a change in appearance of the eyes is one of the commonest things that people will report, either a pushed forward appearance of the eyes or a drawn back appearance of the eyelids. Eyes can often feel scratchy or gritty, like there's sand in them, and to compensate for that, the eyes will often make extra tears, so people find that their eyes are watery. Bright lights can be bothersome, so things like working in front of a computer can be difficult. And going along with that changed appearance of the eyes, people will often notice that their eyelids are different. They might have an increased baggy area under the eyes, or puffiness on the top bit of the eyelids, redness of the eyelids, and even redness of the eyes themselves. Sometimes the vision can become blurred, and sometimes people can actually get double vision. And when the muscles behind the eyes are very inflamed, then people can often get a deep pain in behind the eyes, particularly on eye movement. So thinking about what I can do as an endocrinologist for people with an overactive thyroid, there are 3 main ways in which we treat people with Graves' disease. And bearing in mind that only a proportion of people will have thyroid eye disease, we might use some or more than one of these treatments depending on the person. So I was just going to talk a little bit about the pros and cons of each one, and in particular how they might relate to somebody with thyroid eye disease. We very often use antithyroid drugs, either carbimazole or one called propylthiouracil, which we often shorten to PTU because it's a bit of a mouthful. And both of these drugs will block the production of thyroid hormone. Normally, we treat people for between 12 and 18 months. Why 12 to 18 months? Well, that's because when the immune system makes these TRAb antibodies, they normally peak and then settle down and burn out over about a 12 to 18 month period. So we just need to block the thyroid hormone production until the antibodies settle down of their own accord. And if you're on one of these drugs, hopefully somebody will have told you that there is a rare but important side effect called agranulocytosis, and that's basically where you get a drop in the white cells, and these are the cells that fight infection. So if you have a sore throat, an unexplained high fever or mouth ulcers, you should stop your medication and get a full blood count checked. And again, the BTF have a really excellent leaflet on medication for thyroid disease on their website, which you can have a look at if you have any questions about drugs. The second way that we can treat an overactive thyroid is radioactive iodine, and this is a really successful treatment in that it normally achieves a high cure rate of about 85%, but generally means that the person develops an underactive thyroid. We need to have a little bit of caution in certain circumstances, for example, where young children are at home. But in particular, in relation to this talk, we need to be mindful that radioactive iodine can increase the risk of thyroid eye disease developing or can worsen existing thyroid eye disease. So I'll come back to radioiodine in a little while. And the third treatment is surgery to remove the thyroid gland. And this is something that we very often consider in our patients with thyroid eye disease. And there's a number of reasons why it's a good treatment for people with thyroid eye disease. But the first is that we know that fluctuations in thyroid hormone levels can affect thyroid eye disease and make it worse. So if we remove the gland surgically, it reduces, well, it basically removes the risk of any further flare of the thyroid down the line. So that's one factor that could potentially trigger thyroid eye disease taken out of the equation. But the second reason why surgery is often useful in this group is if we think about what the immune system is doing to cause thyroid eye disease, which is producing these TRAb antibodies, it's the big chunky thyroid in the neck that's the initial thing that the immune system has recognized as foreign and started attacking with antibodies. So removing that thyroid gland tends to reduce the risk of the immune system producing antibodies in future. It doesn't remove it altogether, but it does reduce it. So if we think now about specifically people who have not just Graves' disease, but thyroid eye disease as well, what is my role as an endocrinologist? Well, one of my roles is to pass on information to people. And you see here a screen grab of the BTF leaflet, but also a screen grab of the Thyroid Eye Disease Charitable Trust or TED-CT website, which also has lots of useful information. And our own clinic website, which is edinburghdiabetes.com, also has some information on thyroid disease if anybody's interested. And I've listed there the main things that I do as an endocrinologist. I cover smoking advice. I try and control thyroid hormone levels. I'm involved in either avoiding radioactive iodine or reducing the risk of radioactive iodine affecting the eyes, and in delivering selenium supplements to patients. And then there are a number of other medical treatments for thyroid eye disease, which Justin and I will discuss jointly in our clinic, but I'll leave these for Justin to discuss, and these would include treatments such as steroids. So if we think about smoking first, this is just a picture of the leaflet that we use in our clinic for thyroid disease, for really the importance of stopping smoking for people with thyroid disease. And here's the key fact here, which is that research shows that smokers are more likely to suffer severe thyroid eye disease than non-smokers, and they also respond less well to treatment. And this is really the study where that came from. The table here shows an analysis where they looked at a number of different risk factors, including smoking behavior, age and gender and type of thyroid treatment. And they looked at what's called a risk ratio. And the risk ratio basically tells you what are the chances of developing severe thyroid eye disease. So if you were a smoker, you had a 9 times higher risk of developing thyroid eye disease than if you were a non-smoker. And you can see that those risk ratios are lower for all of the other factors they looked at. So smoking is a really, really strong predictor of severity of thyroid eye disease. And we would always try and support people to stop smoking when they come to our clinic. This next slide really shows some information from a group called TMED, of which I'm a member, and TMED is the Thyroid Eye Disease Amsterdam Declaration Implementation Group UK. It's quite a mouthful, that's why we call it TMED for short. And this was a campaign called TMED 5, which came out a few years ago, and it was really to try and improve outcomes in thyroid eye disease by creating a simple 5-point plan that all endocrinologists would be aware of. And you'll see that I've mentioned a lot of this already, using TRAbs to diagnose Graves' disease. And we also want to alert all people with Graves' disease to the symptoms of thyroid eye disease. And there's an early warning card which TMED developed, and I'll show you a picture of that further on in this talk. At the bottom, you can see referral to a specialist clinic, such as the one that Justin and I run together. But point number 4 was really around prevention of thyroid eye disease or prevention of worsening of thyroid eye disease. And you'll see there that controlling thyroid hormone levels, that's what euthyroidism means, encouraging smoking cessation. These are 2 of the things I've mentioned already. And then the other 2 factors relate to avoidance of risk around radioactive iodine. So just to tell you a little bit more about radioactive iodine and why does it cause thyroid eye disease and what can we do to reduce that risk. So radioactive iodine is actually recommended as the first-line treatment for Graves' disease in the NICE guidelines. And many of you will know that NICE is the National Institute for Health and Clinical Excellence. They produce guidelines that govern how we manage conditions. It's fair to say that even though it's recommended as a first-line treatment, there is regional variation, and it's not the first-line treatment everywhere. In Edinburgh, we tend to use antithyroid drugs as the first-line treatment, partly because of a concern about flaring up thyroid eye disease. And there are many different factors influencing the choice of treatment for Graves' disease when we're weighing up whether to go for tablets or surgery or radioactive iodine, and we can cover that in more detail in questions if people like. But the presence of thyroid eye disease is a really key factor. So if somebody has active thyroid eye disease, we would tend to avoid radioactive iodine. The main concerns around radioactive iodine are that people can often gain weight after the treatment, but also that it can worsen the risk of thyroid eye disease. And there are two main mechanisms behind this. The first is that radioactive iodine often has a direct destructive effect on the gland. In other words, the thyroid gland damaged by the radiation will release protein into the circulation, and that protein in the circulation triggers the immune system to make higher levels of TRAbs, and that surge in the TRAb levels can then cause a worsening of thyroid eye disease. The second factor is that after radioactive iodine, people can often become hypothyroid, sometimes really quite suddenly. And as we've already said, swings in thyroid function, not just to overactivity, but also to underactivity, can flare up the eyes. So these are the two reasons why radioactive iodine can worsen thyroid eye disease. And we know from studies that people who are at particular risk of a worsening of thyroid eye disease after radioactive iodine are, again, smokers, people with severe unstable thyroid eye disease, and people who already have high TRAb levels to begin with. The Cochrane Database is a system in the UK that pulls together evidence from lots of different studies to give us kind of summary evidence, if you like. And the Cochrane Database looked at the relationship between thyroid eye disease and radioactive iodine a few years ago, and basically found that people treated with tablets had a 19% chance of developing thyroid eye disease, whereas people treated with radioactive iodine had a 38% chance of developing thyroid eye disease. In other words, the risk is double with radioactive iodine compared to tablets. So how we manage radioactive iodine is a really important area in relation to thyroid eye disease. And this group, called the European Group on Graves' Orbitopathy, or UGOGO for short, has pulled together multiple guidelines that govern how we treat thyroid eye disease. And our clinic is broadly run on the principles outlined by UGOGO. They advise avoiding radioactive iodine in people with active thyroid eye disease. But if you have to give radioactive iodine because there's no other choice, then you can reduce the risk of a flare-up by giving a course of steroids. And if the person is high risk, you give a higher dose of steroids over 3 months. And if they're low risk, you give a lower dose of steroids over a 6-week period. We're sometimes asked in our clinic about people who have previous thyroid eye disease, which is now burnt out and stable, and whether it might be safe for them to have radioactive iodine. And the evidence would suggest that those people can be given radioactive iodine safely, although sometimes as a precaution, we might give them the lower dose course of steroids over a 6-week period. But if there's any doubt, then endocrinologists should always think about referring somebody for an assessment by an ophthalmologist with an interest in thyroid eye disease before taking the step to give radioactive iodine. We definitely want to avoid it if there is active thyroid eye disease. We've also mentioned that becoming hypothyroid, developing an underactive thyroid after radioactive iodine, can cause a flare-up of the eyes. So I want to tell you a little bit more about that and what we as endocrinologists can do to reduce that risk. And this was one of the studies which demonstrated that link. It was conducted in the Mayo Clinic, which is a very large clinic in the States. And it looked at 195 patients who had had radioactive iodine and who had 1 year of follow-up data. And what this study found was that after radioactive iodine, thyroid eye disease either developed brand new or worsened in 25 patients, and that there was a really strong association between developing hypothyroidism, an underactive thyroid, and developing thyroid eye disease following radioactive iodine. So let me show you some figures around that to demonstrate that graphically. The graph on the top left here shows you patients divided up into those who were already hypothyroid when they came to clinic for the first time after radioiodine. That's the 2 bars on the left. And there's those who were not hypothyroid at their first follow-up. That's the 2 bars on the right. And the dark bar in both circumstances is people who had no Graves' orbitopathy or who had previous disease that was the same, no worse, no better. Whereas the light bar is people who either developed new Graves' orbitopathy, which is thyroid eye disease, or worsening of pre-existing disease. And what you can see is that the number of people developing thyroid eye disease was much higher in the group who were hypothyroid than in the group who were not hypothyroid, giving a roughly 3 times risk of developing thyroid eye disease if you had an underactive thyroid at that first appointment. The graph on the right also shows how quickly people can become hypothyroid. So on the bottom part of the graph, we've got the time after radioactive iodine, and then each bar is divided up into colors. So the black shows the proportion who were still hyperthyroid with an overactive thyroid, and then the light bar at the top shows those who were hypothyroid. And if you look at the second bar, the 6 to 8 week mark, which is often where we're seeing people after radioactive iodine, you can see that already 40% of people had developed an underactive thyroid by this point. So if we take all of those facts together, what do we as endocrinologists need to do to reduce the risk of eyes flaring up in relation to thyroid eye disease? Well, the first thing is really careful patient selection. If somebody's got active thyroid eye disease, then as endocrinologists, we should not be recommending radioactive iodine unless there's absolutely no other choice. And if there's no other choice, then we should be using some steroids to protect the eyes, usually at the higher dose for 3 months. If people are at lower risk but still at risk, then we would use the lower dose course of steroids over 6 weeks. It's important to be very upfront with people about the risks of thyroid eye disease. And this is the thyroid eye disease warning card that I mentioned earlier, which was developed by TMED. And I'll very often give this to people to say, if you get any of the symptoms listed there, let us know because we want to see you very soon in clinic. And it's important for us as endocrinologists to avoid hypothyroidism after radioactive iodine. And again, if people want to discuss this in more detail in questions, we can do so. But the way I do it is using a combination of tablets called block and replace. So we use carbimazole to block the thyroid completely and then give thyroxine, which is thyroid hormone replacement, and the combination of one drug to stop the thyroid being overactive and one to stop it being underactive tends to hold the thyroid function in a stable position and avoid that hypothyroidism. But if you're on carbimazole or PTU alone, it's really important that you get an early check of thyroid function. I'd say ideally no later than 6 to 8 weeks after your radioactive iodine. The final thing that I'm going to talk about for my last couple of slides is a treatment called Selenium, which many of you might have come across and is mentioned in the BTF leaflet on thyroid eye disease. And this study was produced again by UGOGO, the European Group on Graves' Orbitopathy. And in this study, you can ignore the flow chart on the right-hand side, which looked at a treatment called pentoxifylline, because those results were not significant. And we can just focus on the results in relation to Selenium, which was compared to placebo, with 52 patients on placebo and 55 on Selenium. And patients were given this for 6 months. And they had a number of assessments. They filled in a questionnaire called the GeoQoL, which is the Graves' orbitopathy quality of life score, and that looks at appearance and also function of the eyes. They also had an overall eye evaluation with many different eye measurements, and Justin will talk about some of the eye assessments that we tend to do in clinic. So if we look at the graph on the left first, which is the quality of life, and we look, the Selenium is the first group of 3 bars, then placebo, which is dummy tablets, is the second group of 3 bars. And what you can see is that the light colored bars are the people who improved. And in the Selenium group, you can see that over 70% of people improved over the 6 months that they were treated. Whereas in the placebo group, only about 25% improved. And if you look at the dark blue bar, you see that over 45% of people deteriorated in the placebo group compared to about 18% in the Selenium group. So people generally had improvements of quality of life. And on the eye evaluation score, you see the same pattern. Many more people improved on Selenium than on placebo, and many more people got worse on placebo than on Selenium. Selenium also reduced the clinical activity score, which Justin will talk about later. And in particular, the improvements on the eye measurements were in relation to the eyelids and the soft tissues. This graph shows what happened when people finished their 6 months of treatment and then were seen 6 months later, so 12 months after the start of the study, and basically the graphs are almost identical. What that tells you is that 6 months of selenium tends to continue to have benefit for a good year in total. Nobody reported any side effects on selenium, so it's a very well tolerated drug, and that's something that we would distribute to people in our thyroid clinic and in our joint thyroid eye clinic. So I'll now hand over to Justin, who will talk about some of the other treatments that we use in our clinic, much of which is based on the UGO-GO guidelines.
Thanks, Nicola, and thanks for having me to speak at this webinar. So I'm a consultant in medical ophthalmology, and alongside Nicola, I do a weekly thyroid eye clinic here in Edinburgh. So I wanted to talk about thyroid eye disease from an ophthalmologist perspective, but actually I wanted to start by sort of stepping back and thinking about, the patients that I've seen over the years with thyroid eye disease who come to the eye clinic for the first time and what their concerns tend to be. And one of the concerns that comes up quite a lot, which often takes us by surprise, but is a genuine fear for many patients that come to see us, is will I go blind? Unfortunately, the answer to that is that it's very, very unlikely that you will lose vision from thyroid eye disease. And even if patients are in that small category of patients with thyroid eye disease who are at risk of losing vision, there's plenty that we can do to try and ameliorate that. Patients often want to know, will this get worse? And it can be difficult at that first visit to know if somebody's thyroid eye disease is, at the end of its active phase and that it's settling down, or if it's going to change over time. So often it's hard to answer that question at that first visit. And we sometimes need to build in, or we often need to build in a bit of follow-up in the clinic to find out at what stage we're at in the thyroid eye disease journey. Patients will want to know if they need treatment, and the answer to that is in fact not always. Beyond what Nicola's talked about from an endocrinology perspective, we don't always need to do very much more from an ophthalmology or in the joint thyroid eye clinic for treatment, but there are options available if we do need to. Can this be treated? Well, yes, and we're going to talk more about the sorts of treatments available for the rest of this talk. What is the treatment? We'll talk about that in the rest of the talk. Can I drive? So driving comes up a lot in all eye clinics, and particularly in the thyroid eye clinic. And the answer for most patients is yes. And this is particularly relevant to patients who develop double vision. There are some important things to point out if you have double vision around driving. So we'll talk about that a bit towards the end of the talk. And is there anything that the patient themselves can do? And I think Nicola's really summed that up very succinctly. And we understand that smoking is extremely difficult to give up, but it really does make a huge difference to patients' thyroid eye disease if they can reduce or even stop smoking. Alongside selenium supplementation that we've talked about, and also working with the endocrinologists to try and normalize thyroid function. So I just wanted to revisit some of the symptoms of thyroid eye disease. So as Nicola mentioned, change in appearance is one of the main ones, and that can be due to a combination of factors. So you can get puffiness around the eyes, which can cause a change in appearance, but patients can often comment that their eyes have a wide-eyed or a bulging appearance or a staring appearance. And this can be due to two things. So one of them is the eyelid position, which tends to pull up above the eye, and we call that lid retraction. But the other thing that can happen in thyroid eye disease is that we have an increase in the amount of fat in the eye socket and the size of the muscles in the eye socket, and that can push the eye forward. And when the eye is further forward than it would naturally be, we call that proptosis. And that word will come up quite a bit during the rest of the talk. As Nicola said, patients can get a dry and gritty eye. Pain can be a feature of thyroid eye disease, often a pain behind the eye or sometimes a pain when you're moving the eyes. Patients can get double vision. Patients can also have a raised eye pressure, and in fact, most of the time, you wouldn't know that your eye pressure is high. It's only when it's measured by an optician or an ophthalmologist when we find out that the eye pressure is high. And that's important because a high eye pressure can contribute to glaucoma in the eye and can cause visual loss. And as I say, it is very rare for patients to lose vision in thyroid eye disease, but it is a possibility, and it's something that we have to be very alert to in the eye clinic. And loss of vision can be due to the nerve as it leaves the eye and goes through the eye socket into the brain, the optic nerve. That can be compressed by this enlargement of the eye muscles or increase in fat. Or the other thing that can cause loss of vision in thyroid eye disease is if the eyes are pushed too far forward and the eyelid is not coming over the eye surface and the tears are not moisturizing the eye surface, then the eye can be exposed and we can get loss of vision through that mechanism. So I just wanted to focus in on one of the things I've mentioned there, which is lid retraction. So it's quite common, especially in patients who are hyperthyroid or have an overactive thyroid when they present with thyroid eye disease. And this is one part of thyroid eye disease where it definitely can gradually resolve and improve as thyroid function is controlled. So this is one situation in thyroid eye disease where things can often get better by themselves, and we very much want to adopt a kind of watch and wait strategy. But one of the big things that we want to assess if we have a patient with thyroid eye disease in the joint clinic is the disease active or inactive? And it's important because active disease might respond to some of these immunosuppressive treatments that we've talked about, such as steroids or rituximab or mycophenolate are common ones that are used. And you can think of activity in thyroid eye disease as a bit like a house being on fire. If a house is on fire, it's active and a dynamic situation, it's unstable. And during the fire, you want to focus all your efforts on putting out the fire and reducing the inflammation. And the way we reduce the inflammation in thyroid eye disease is with these anti-inflammatory immunosuppressive treatments. And when the house is on fire, you wouldn't start rebuilding or repainting until the fire is settled. Once the fire has gone out, trying to put out the fire is not going to improve the situation. So there's no response to these immunosuppressive treatments once the active phase has finished. And what we tend to do, much like a house that's had a fire, we wait for a period of time to make sure the embers don't rekindle, and then we start rebuilding. And we'd start with the structural work first, and then we want to do that before we move on to the redecorative or cosmetic work. So we can think of our eye surgeries in that order as well. So we can look for activity using the clinical activity score, which I'll talk about in a bit more detail in a second. The TRAB antibody levels can be helpful. We can also use MRI scans because that can show us what's going on behind the eyes more than we can see in the clinic. And what we want to decide is the patient with thyroid eye disease in this stage here, which is relatively short-lived at the start of thyroid eye disease, where medicine is going to make a difference. And if we intervene at this point with medicine, then we can make a difference. But sometimes patients present to us when the inflammation has gone, but they're still experiencing severity or problems with thyroid eye disease because of past inflammation. And at this point, we don't want to give patients medication, which won't make a difference. We want to think about surgical options to help patients. So the clinical activity score, it's basically a score that's out of 7 on the first visit with a patient or out of 10 on subsequent visits. And it's based on a lot of the symptoms that we talked about. So pain, retrobulbar, meaning behind the eye, pain on eye movement, which can often be a sign of activity. Redness of the eyelids is kind of similar to how it's described. Redness of the conjunctiva, so that's if the white of the eye is red. Swelling of the eyelids, and there can be a few different mechanisms for swelling of the eyelids in thyroid eye disease. So I'm going to talk about that in a bit more detail in a couple of slides' time. Inflammation of the caruncle and the plica. So these are the little folds of conjunctiva that are in towards our nose. that are the remnants of our kind of third eyelids that birds have and alligators have, but humans don't have anymore. And these are normally, you know, very comfortable and not inflamed, but can sometimes get inflamed in thyroid eye disease. We look for conjunctival edema, or we sometimes call that chemosis. So that's little blisters of fluid underneath the conjunctiva on the surface of the eye. And we also look for changes in function. So we need follow-up to look for these changes in function. And that can be a reduction in eye movements, a reduction in visual acuity, or an increase in proptosis, or the bulging in the eye, as time goes on. So when you come to the eye clinic, you might be familiar with these kind of measurements. So this is an exophthalmometer that we use to measure proptosis. And it sits quite tight either side of the eye, and we look in the mirror to the sides that can tell us the position of the eye. We might also measure the eye pressure, sometimes done in the optician with an air puff. In the eye clinic, we tend to do it with an applanation tonometer that actually contacts the eye once we put anesthetic in the eye, and we get the pressure through that. So eyelid swelling. So sometimes in thyroid eye disease, I mentioned that we can get an increase in the amount of fat in the eye socket. And sometimes this can actually bulge forward and essentially cause swelling around the eye, but it's not the active fluidy swelling that we're looking for to measure activity. Similarly, if you've had fluidy swelling in the eyelids, once it settles down and things are inactive, then you can be left with excess skin. Which again gives the appearance of swelling, but doesn't come into the category of active eyelid swelling. So in these top pictures here, we wouldn't score these as active because it's more to do with fat coming forward or excess skin because of previous swelling. But in these bottom pictures, there's a more tense appearance, a more fluidy appearance to the swelling. So we would score that on the CAS score. This is just a picture of conjunctival edema or chemosis, and sometimes looking in the mirror, you might see it as like a small blister on the front of the eye. And this is the plica and caruncle that I mentioned, just in towards the nose and the eye. They normally look very pink and sort of whitey pink and innocent, but sometimes they can look quite red and inflamed in thyroid eye disease. And an MRI scan, as I say, not all patients with thyroid eye disease that's active will have a high CAS score, particularly if a patient's got pain on eye movement or proptosis, but not much to see at the front of the eye. Might do an MRI scan. It might show enlarged eye muscles such as this, and the muscles might be whiter than they should be on MRI scan, suggesting they're more watery than they should be, and that can suggest activity as well. So if we have active thyroid eye disease, our mainstay of treatment, again in the UGOGO guidelines that Nicola mentioned, is intravenous steroids. And it's usually given once a week over 12 weeks as an intravenous infusion. We give the intravenous infusion instead of tablets because it tends to be better tolerated and it's been shown to be more effective. However, we know that steroids can and do have side effects. So they can cause weight gain, they can contribute to high blood pressure, predispose patients to diabetes and mood change during the treatment. And even after the treatment's finished, they can leave patients at increased risk of bone thinning and osteoporosis later in life. So when we have a patient with thyroid eye disease, I very much like to have a discussion with the patient, with Nicola, about what the best way forward is and if the patient wants to take treatment for thyroid eye disease. And a lot of that's to do with severity of the disease, the patient's underlying health condition, and what the patient's preference and attitude to side effects and risk and so on is. So in our clinic in Edinburgh, in a specialist thyroid eye clinic, it's in fact only about 8 to 10% of patients who go on to the stage of needing steroid treatment. So we give the steroids over 12 weeks, we review at the end of the treatment, and then about 4 to 6 weeks later. And for the majority of patients, they'll get benefit, they'll maintain that benefit, and things will either settle down or things will be inactive. And once we get to this sort of 6-month time point, we will then think about referring on for surgery. However, for some patients, they get an improvement with the steroids, but it can rebound, within a few months after giving steroids. And in that situation, we'll think about second-line treatment. So on this slide, I've named quite a number of different second-line treatment, all of which are mentioned in the UGOGO guidelines, all of which have some evidence behind them to help in thyroid eye disease. And what you'll often find is that the choice of treatment depends on your local specialist clinic throughout the country, where their local what their local expertise lies in, and the availability of treatment around the country. So for example, in Edinburgh, we very frequently will use rituximab as our second line treatment for thyroid eye disease. For inactive disease, we talked about using surgical interventions. There's also non-surgical things we can do, and we can use this in active disease as well. One of the key things, and we talked about dry and gritty eyes, is to use lubricating eye drops. I find lubricating eye drops very confusing. There are loads of different ones out there. So I think it's a good regimen to have is to have a drop that contains sodium hyaluronate, 0.2 or 0.18%, using that during the day. Or another one that's quite common and quite good is carbomer gel, 0.2%. If you're using drops more than about 4 times a day in thyroid eye disease, I would say to go on to a preservative-free preparation, because if you're using preservative containing drops, that can sometimes build up in the eye and cause irritation. And for patients that have severe dry eye, or if they have eye exposure at night because of what we call lag ophthalmos, where the eyelid doesn't come down over the eye enough, we suggest using an ointment. So that's common ones are Xylanite or Hyalonite. They're quite thick. Some patients don't like them because they're too sort of thick and gunky, but they give very good lubrication and protection to the eye overnight if they can be tolerated. For patients that have double vision, you might be assessed by an orthoptist. And one of the things that they will do is measure you with a prism bar to see if we can correct the double vision with a prism, and then such as here. And then once we've found what prism strength will help, we can use a stick-on prism to your glasses, or to a set of glasses that don't have a prescription in them with just a plain lens and a prism. And the thing with thyroid eye disease is that your prism strength can change over time. So it's a good idea to use these temporary stick-on prisms. And then if the disease settles down and the prism is stable, you can then either have that incorporated into glasses, or at that point consider doing squint surgery, which we'll go on to talk about in a second. I just want to briefly mention double vision and driving in the DVLA. So if you develop double vision, you must cease driving and inform the DVLA if you're a driver. However, most patients will be able to return to driving. A lot of people don't realize that actually you can legally drive with one normal eye. And so patients can drive with either one eye patched or a frosted lens put over one eye in glasses. You have to feel able to drive with one eye. So I often tell patients to be a passenger in the car with one eye covered. If your double vision is corrected with prisms, and these are stable, again, you can return to driving with your prisms. And stable and being used to it usually means that we're able to say to the DVLA that you've had 3 months of getting used to the prism or having the eye covered. So in the inactive phase, a number of our patients will offer surgery to. Often patients will require maybe more than one surgery. For proptosis, or if a patient's, the rare patients that are experiencing loss of vision with thyroid eye disease, we offer decompression surgery. And that's actually surgery that removes part of the bone of the eye socket. It's done under general anesthetic, and it can be very effective at helping bring the eyes back into a more natural position. If patients have double vision, then we'll refer them on to a strabismus surgeon or a squint surgeon, and they will adjust the position of the eye muscles and aim to get a patient eliminating double vision when the patient's looking straight ahead. And the last surgery that we do once we do the other surgeries, if we need to, is eyelid surgery. Sometimes that can be because the eyelid is still sitting too high, or if a patient has had a lot of eyelid swelling and is left with excess skin or excess tissue, that could be removed with eyelid surgery. And this is just an example from the American Academy of Ophthalmology of a patient who has decompression surgery. And you can see that actually after the decompression surgery, a lot of the swelling around the eye improves. So the patient then doesn't really need to have surgery done, particularly with these lower eyelids. So it's always good to do the surgery in the correct order. So in summary, thyroid eye disease can vary in severity and requirement for treatment. Lifestyle factors can really help, particularly smoking, as we've touched on. For us in the Thyroid Eye Clinic, it's important to distinguish between active disease and inactive disease. For active disease, the mainstay of treatment is medical treatment. For inactive disease, the mainstay of treatment is surgical treatment. But in thyroid eye disease, for most cases, the decision really depends a lot on the doctor and the patient being open about the treatment options and deciding on the best course of action. And many patients don't actually require additional treatment over and above very simple measures like controlling their thyroid function, trying to stop smoking, and taking supplements like selenium. So I'll leave things there, and I think we'll open up for questions.
Thank you so much to both of you. That was, I think I've never had such a comprehensive tour of thyroid eye disease and the different treatments. That was really, really helpful. Thank you. We've got lots of questions. So to start off, I'll try to put some of them together because some cover the same topics. Somebody saying they think they've got thyroid eye disease. How do they get a referral? And we often hear this from patients. How do they get to be seen by an eye specialist to confirm the thyroid eye disease?
So I think that the routes into the Thyroid Eye Clinic that we get are from the endocrine clinic, from the thyroid clinic, from patients' GPs, and in Scotland we'll also get referrals from opticians. So those are the main sources that we get from we get referred in from.
Patients who get to go to a joint clinic like yours are very fortunate, but we know that there aren't joint clinics everywhere. Do patients have a right to request to be referred to see a joint clinic where they'll get to see more than one specialist?
So as you say, Juliet, it depends a little bit on what's available locally. I mean, we've had our joint clinic running for about 11 years now. Prior to that, there was an ophthalmologist with an interest in thyroid eye disease, but you saw him separately to the endocrinologist. In some regions, I mean, we think it's ideal to have the endocrinologist and the eye doctor co-located because, for example, when Justin thinks from an eye point of view that somebody might need steroids, but say they've got diabetes and we know the steroids might push up their blood sugars, I'm there as a sort of endocrinologist and general physician to advise about those things. So we really can make joint decisions. But if fundamentally, if somebody's got problems with their eyes and there's a specialist who can see them on their own without an endocrinologist, then they may well still be able to get a lot of the intervention that they need. So it depends a little bit on what's available locally.
Yeah. We've got a question here that says, if proptosis appears only in one eye, does it mean that there are more chances of thyroid eye disease is weaker and will go away with time? Or does it mean that it will affect the other eye sometime later?
So it's actually pretty common for proptosis to be asymmetrical in thyroid eye disease. And what we sometimes find is that a patient might be aware that one eye is more proptosed, but when we measure the eyes, the other eye is a bit proptosed, but relative to the eye that's more proptosed, it's not quite as noticeable. So we do occasionally see cases that have, I can think of one case that had one eye, many years ago, and then presented, I think it was 5 or 10 years later, and the other eye started to develop thyroid eye disease. But those cases are quite rare, and the more usual pattern of events is that a patient has, an initial active period of thyroid eye disease, and then once that's settled, there's no further reactivation. So if your thyroid eye disease presents with one eye more than the other, once the disease is inactive, that tends to be for them in the majority of cases. Unfortunately, you can never say never, but in the majority of cases, that tends to be, how the disease, it doesn't tend to recur in the other eye. Yeah.
So once somebody's been diagnosed with thyroid eye disease, they will they always have thyroid eye disease, but hopefully inactive? It will settle down to being inactive, and they should just be aware of it for the rest of their life? Or can it be seen as cured? Is it something you can refer to as being cured or inactive?
I would be a bit cautious about using the word cured, but inactive certainly. And it's studies kind of vary, but I think it's reasonable to say between 80 to 90% of patients have what we call a monophasic or a one-off disease course. So recurrences of thyroid eye disease, they can occur, but they are rare. And Nicola will probably be able to tell you, more that sometimes, for example, if a patient loses control of their thyroid function for whatever reason and goes into hypothyroidism, that can sometimes precipitate a recurrence of thyroid eye disease. So all the more reason to, maintain good thyroid function.
Yeah, we've had a few questions about that. I'll come to in a bit. Can you tell us something about future treatments? I know, Justin, you mentioned a few potential treatments, and I know that there was some treatments, tetratumumab, which has been talked about, and on our Facebook group, patients get very frustrated to read about these treatments that aren't available in this country. Is this the future of care for patients, drugs like this, and are there others in the pipeline, Nicola?
So tepratumumab and other treatments are mentioned in the UGOGO guidelines, and there are other treatments in development. But thinking about tepratumumab in particular, the thing that tepratumumab has that other medical treatments don't have is that it actually improves proptosis, so that pushed forward appearance of the eyes. Steroids don't tend to do that. Rituximab doesn't tend to do that. And often if people are still significantly proptosed, then they need decompression surgery afterwards. So the argument with tepratumumab is that it could potentially avoid the risk for decompression. There's a few problems with tepratumumab. One is that in the research studies that have been done so far, it's been compared against essentially no treatment. So there are many studies that show tepratumumab is better than doing nothing, but actually there aren't as yet any studies that have compared tepratumumab to intravenous steroids, which is normally our first-line immunosuppressant treatment for thyroid eye disease. And what we also don't know really is, is tepratumumab better than steroids and then orbital decompression for some patients? Because of course, as Justin says, some people do recover with time and then don't need surgery subsequently. One of the other things with tepratumumab, sort of elephant in the room really, is the cost. So Simon Pearce, who's a very eminent thyroidologist, did an editorial on this, and I was shocked to look at the figures that he put in his editorial. So in the States, a 12-week course of intravenous methylprednisolone costs in the ballpark of $330, whereas a course of tepratumumab costs $300,000. So when we're talking about expensive, we don't just mean a bit more expensive, we mean a lot more expensive. So when we're looking at a publicly funded healthcare service such as the NHS, we do need to weigh up, is that extra, 299,000 odd pounds worth it? Does it have enough benefit to justify that cost? So as things stand at the moment, it's licensed in the States, but it's not licensed in Europe, and it's not licensed in the UK. And I think that in order to get that license, it would probably need to do some studies against intravenous steroids, which is our kind of go-to first-line immunosuppressant treatment. So I don't see it coming in the near future, but it might do in due course.
Thank you. We'll keep an eye on tetratumumab. Here's a question here about antibodies. So I'm going to read it out because it's quite difficult for me to summarize it, and I'll probably get it wrong. Thyroid eye disease starts with the active inflammation. In the milder cases, when you're going towards the burning out stage, is there a decrease in the autoimmune response? Let's say the attack gets weaker, or is there a residue of antibodies attack? What about the chronic stage? When does it stop? Is it when it does stop? Is there a heavy burst and the damage is done? So In the milder cases of thyroid eye disease, in the burnt out phase, when the muscles have been damaged, is there a chance of any reversal? Or are the muscles then damaged and scarred and they'll stay enlarged, and the only option is then orbital decompression? Sorry, it's a long-winded question,
okay.
but I think I'm sure
I might cheat a little bit for part of this and just say that the November 2020 webinar that you guys had, Rashna Murthy and Jonathan Roos have actually published on TRABs. They published quite a number of papers on TRABs, and they referred to those in their webinars. So people might want to go back and watch that webinar, because there were some research studies on TRABs. There are definite studies that show that there is a link between the TRABs and the sort of time course of the disease. But it's not a completely hard and fast rule. And we have seen people in this clinic who've had persistently high TRABs, but their eye disease has settled down and remained stable. So it's not a completely 100% together relationship, in the same way as it's much more common for the eyes to be active and the thyroid to be active at the same time. But we see some people where only the eyes are active or only the thyroid is active. So they often go together, but not completely hand in hand, would probably be my summary. And Rashna Murthy and Jonathan Roos are experts in this area and have published in it. So that might be a good source of more detailed information on TRABs. I don't know if Justin wants to add anything to that.
Well, I mean, in terms of the eye muscle question, so I think that once the disease is inactive, then I'm just trying to remember the exact question, but I think the bottom line is that it is fair to say that once the disease is inactive, if patients are left with residual double vision or proptosis, then often the options for that are surgical. But the surgery is actually very in many cases very successful. And patients get good outcomes. Understandably, a lot of patients are quite apprehensive about surgery, but so it's really about talking them through the process, talking about risks and benefits, and referring them for surgery at the right time. But if it does come to that, then the outcomes from surgery are often very positive.
That's great to know. That covers a few of the other questions we've had. You've talked a lot about smoking, which is a really important message. We're often asked about vaping and nicotine gum. Where do they come into play with regard to thyroid eye disease?
I think the answer is that we don't completely know. We think it's probably better to vape than to smoke, but we're fairly certain that it's better to not smoke at all than to vape. So if vaping is your pathway to not smoking, then that's great. If vaping is as much as you can manage and you can't get off altogether, it's probably better than smoking, but the general sort of wisdom is that if you can cut out altogether, that is the best. I did see there was another question there about secondhand smoke, and again, I'm not sure that there've been any studies done on that. I'm not aware of it, but I guess what I would say is, if you're somebody who's trying to smoke in a household where other people are smoking, that's incredibly difficult. So when somebody comes to clinic and we talk to them about smoking, I usually ask who else in the household smokes, because if the husband is there, and I say husband because most of our patients are women, but if the husband is there and he smokes as well, I will take the opportunity to say, you really need to try and stop with your wife, because it's really difficult to stop if the house is filled with smoke.
And nicotine gum, has there been any research about nicotine gum? Is the nicotine itself, could it trigger thyroid eye disease?
I think I think the nicotine gum will be the least worrisome of all. I'm not aware of any link directly with nicotine. I think it's more the sort of toxins in the smoke, if you like, rather than the nicotine as such. So we're very comfortable with people using nicotine gum, and there's a range of medications. Again, we've had some patients in the past using medications to help with the cravings. All of those smoking cessation treatments are all absolutely fine.
That's good to know. Here's a question from your colleague, Dr. Mark Strachan. Mark says, in practice, would orbital radiotherapy still be carried out for thyroid eye disease these days, given the availability and the wide array of biological immunosuppressants?
the short answer is yes. So there is the evidence for orbital radiotherapy. I mean, it's been a mainstay of treatment of thyroid eye disease for a long time. There was a recent study, the CERTED study, where it didn't come up as a disease showing, you know, a difference or an improvement in thyroid eye disease. I think I'm right in interpreting their outcomes in that way. But having said that, there is a lot of experience of using orbital radiotherapy, and particularly for patients with significant eye muscle disease and double vision. There's a consensus that amongst quite a lot of thyroid eye doctors that it can be an effective treatment. It can, again, availability for orbital radiotherapy can be challenging, we in our local clinic we tend to favor rituximab, but we do occasionally refer patients for orbital radiotherapy. So again, that's one of those issues that's maybe a bit related to local expertise and availability. Yeah.
Thank you for that. And this is a question we get that comes up quite often as well, often in our Facebook groups. You explained pretty clearly, Nicola, about the importance of, or the risks of becoming hypo post-radioactive iodine therapy. Somebody here is saying that my thyroid eye disease is not currently active, but I've been advised to keep my TSH constant. Despite taking my thyroxine consistently, my TSH has varied between 0.05 and 4.32 over the past 15 months. Is it okay for the TSH to vary within the normal reference range, or does it need to be more stable than that? And are there any other tests that could establish the reasons for TSH fluctuation?
So it's fine for it to vary within the normal reference range. And in fact, if you take somebody who's got a completely healthy thyroid and you measure their TSH at different times during their day, actually the person's TSH will fluctuate even within a day. And that's partly because it's a little bit like the central heating system at home. You know, when you've got it set to keep your house at a certain temperature, the central heating will switch on and off as needed to keep the temperature constant. So, you know, your pituitary gland will turn on and off the TSH as needed to meet the requirements of the body. So we would never expect somebody's TSH to be absolutely rock steady and identical from one day to the next. As long as it's remaining within normal limits, we're comfortable with that. What we want to avoid is it going significantly out with the normal limits.
Yeah. And with regards to selenium, we've got quite a few questions about that. What's a safe level of selenium supplementation? And we can see that the studies looked into taking it for up to 12 months. What about taking it? Is it okay to take it for the rest of your life? And at what dose, if so, are there any risks to that?
Yep. So the study gave it at, it was 200 micrograms a day. They actually split it into 100 twice a day, but quite often for convenience, people will just take 200 once a day. So 200 micrograms a day for 6 months, and then they stopped it. And when they checked people having been off it for 6 months, the benefits had persisted. So on that basis, the study authors concluded that 6 months treatment was enough, because after another 6 months, people were still fine. So you don't have to take it for longer than that. Having said that, we very often have people in clinic who ask, can they keep taking it? And the answer is yes. We don't think it's going to do any harm. The amount of selenium, so 200 micrograms of selenium is equivalent to 2 or 3 Brazil nuts a day. If you want to have that instead of selenium, you know, as a longer term, more palatable option, and my choice would be the ones that are covered in chocolate, but that's optional. So there's no problem being on it long term. We know that if people, so looking at what the long term problems might be, if people are on a bigger dose, so double the dose that we're recommending, 400 micrograms for very long term, people can sometimes get side effects, a metallic taste in the mouth, change in their hair, change in the nails. So I think if you were on selenium for a long time and were getting any funny taste, funny nail, funny hair symptoms, it might be worth coming off it. But at the dose that's recommended, we don't think it'll do any harm. It's just that it's probably not necessary beyond that 6 months.
Thank you for that. And we know that thyroid eye disease obviously most usually affects people with Graves' disease, but it can also affect people with an underactive thyroid. How common is that? I mean, do you ever see that?
Yes. I mean, it's the majority of people who come to this clinic either have overactive thyroids or they've had a previous overactive thyroid, which has been treated with radioiodine or surgery, and they're now on thyroxine. But we do see some people who have only ever had an underactive thyroid. Interestingly, these TRAB antibodies, when we see them in association with Graves, they're what we call stimulating antibodies. In other words, they're antibodies that attack the thyroid to stimulate it to be overactive. But you can also get blocking TRABs, which block the thyroid and make it underactive. So what we think is that the people with underactive thyroids and thyroid eye disease probably always had Graves, in the sense that what they had was TRAB antibodies, but they had blocking TRAB antibodies that made their thyroid underactive. And the even less common variation that we sometimes see as well is people whose antibodies can sometimes flip from being blocking to being stimulating. So that's the least common scenario of all. The most common is overactive thyroid, but we do see a small minority of people with autoimmune hypothyroidism, positive TRABs and eye signs, and then very occasionally we see people who might flip from one to the other. And that's one of the reasons why it is good to have an endocrinologist in the eye clinic to sort of muddle through the blood test side of things while Justin worries about the eyes.
The antibodies are always a constant source of confusion. For us, it's really difficult to keep a track. It's not. Let me just see. Are there any other vitamins or mineral supplements that you would recommend people take that might protect their eyes, or is just really selenium is the key one?
I think mainly in the context of thyroid eye disease, selenium is the main one we'd recommend. I can't think of any others that we'd specifically recommend. Yeah.
Here we have somebody who has double vision, somebody who's developed double vision, but only noticeable in the evening when watching TV. It tends to be worse when I've been working all day at my computer. I wear contact lenses during the day and don't appear to have a problem when wearing them. In fact, they seem to improve the condition. Is there anything I can do to improve my double vision just in the evening when I'm wearing glasses?
I think it's not uncommon for patients who have, keeping our eyes looking straight ahead and not having double vision and synchronized with each other, even if you don't have thyroid eye disease, takes effort because it involves quite a lot of muscles and it's quite energy consuming. So it's not uncommon if people have an underlying tendency to squint for it to get worse when they are tired, sort of last thing in the day, just as the questioner is describing. And also if you have a strong glasses prescription, then you can be a bit more prone to having an underlying squint. So when I say an underlying squint, I mean an underlying tendency to squint, but most of the time you're compensating for that because you are, you're using your muscles to keep the eyes synchronized together. So I wonder if the double vision that's being described, just from what the questioner is describing, it might be a non-thyroid eye related double vision that they're experiencing. So I'd maybe be seeing an optician and possibly getting referred up to an orthoptist if the questioner's not already in, a thyroid eye clinic or that sort of thing. So
lots of other reasons for double vision.
Yeah, it's not always due to thyroid eye disease. Yeah.
And I'm aware that we've gone over our time, so I'm just going to put one final question in now, and we'll pick up the questions from the Q&A, and we'll get them answered for everybody and add them to a transcript of the evening. So keep in touch with the website, everybody, and you should see your question answered there. This is from a 13-year-old child who has Graves' disease and thyroid eye disease since July 2019. And they tell us that they are asking how long will their eyes be active? When will it burn out? They're currently on carbimazole, but hoping to have radioactive iodine treatment as an option rather than surgery. How long can they expect it to be active?
Difficult question. And we were just chatting before the start of the webinar about how Graves' disease is more common in young adults than in children, and really the majority of patients that we see in this clinic are adults rather than children, and children do sometimes kind of behave a little bit differently to adults. And I suppose the other thing is that everybody is a little bit different, but I mean, the active phase can vary for different people, but probably kind of a ballpark of kind of 18 months-ish sort of would be some people a bit longer, some people a bit less, but you know, we normally sort of say to people, think about 18 months rather than 2 or 3 months or 6 months, because there's also the burning out, but then as Justin described, the wanting to be sure that things are stable. And very often before we move on to do something, we often like to see that people have been stable for a good 6 months, you know, just to make sure that nothing's sort of bubbling under the surface. But I don't know, Justin, whether you want to comment on that.
Yeah, I mean, I think so. We normally have this sort of 6-month ballpark figure if we're thinking about referring for eye surgeries, you know, just to make sure things are stable. I think it's very difficult in the question, you know, about radioiodine, because as Nicola outlined, you know, we are very cautious about radioiodine in patients that have had thyroid eye disease. So it might be that the team are wanting to, you know, it may be the eyes are inactive, but they want to make absolutely sure before they go ahead and you know, think about giving something like radioiodine. So yeah, it's very difficult. It's a good question, but a very difficult one, I'm afraid. Yeah.
And actually, linking into a bit of what we were talking about earlier with some of those second line immunosuppressant treatments, there is research going on at the moment into rituximab, which is one of the treatments for thyroid eye disease, but looking at that as a treatment for Graves' disease, particularly in young people. And there's been a sort of pilot study done already, and Edinburgh was one of the centres that took part, suggesting that giving rituximab to young people with Graves' disease reduces the risk of future relapse. So, you know, I think as time goes by, we will see further research in the area of Graves and the area of thyroid eye disease. There may be some treatments that become common to the two of them, and hopefully we'll see expanding options for both the thyroid and the eye side of things.
Well, thank you so much to the two of you. I'm going to finish the questions now. I'm really sorry we had amazing 62 questions, but we will go through them all and do our best to answer them and put them into the to the transcript of the webinar, so you can all see your questions. And of course, if anybody has got any further questions, I'm going to share my screen if I can. Yeah. If anybody's got any questions that they would like to have answered in the meantime, you can always contact us via our medical query helpline. That was a wonderful, really interesting webinar. We've all learned so much. Thank you so much. Anybody who joined late, if they want to go back and listen to any bits again, or to send them on to anybody else you know who might benefit from listening to the webinar, then you'll find the webinar recording on our website in a few days' time. Any questions you're welcome to get in touch with through our normal webinar medical question query service. There's lots of information on our website about all aspects of thyroid disease, and how to manage it on our website. So please have a good look around our website for more information. We've also got a wonderful closed Facebook group for thyroid eye disease. So if you're not a member of that and would like to join it, you'd be very welcome. If you're able to support BTF in any way by becoming a member or to donate, that's easy to do so by our website, and that will enable us to continue doing our work and carrying on events like this. So once again, thank you so much to our wonderful speakers, Dr. Nicola Zammitt and Dr. Justin McKee. We know how busy you are, and we're so grateful that you gave up your time to speak to us tonight. And a huge thank you to everybody who joined the webinar tonight and asked such interesting questions. Please stay in touch with the BTF for future events. We've got a webinar coming up in March about hypothyroidism, which would be of interest to many of you, I'm sure. And we have a thyroid surgeon speaking at that meeting as well as an endocrinologist. And we have another meeting coming up in June, especially for young people with thyroid disorders. So that might be interesting to some of you as well. So thank you again. Thank you for joining us, and enjoy the rest of your evening. Good night.
Thank you.